The next speaker is Dr. Sam Ahn. He's a board-certified vascular surgeon and fellow of the American College of Surgeons. He received his MD from the University of Texas Southwestern. He received his general and vascular surgery training at UCLA. He was a professor of surgery and director of endovascular surgery at UCLA. He sits on the editorial boards of several scientific journals, and he's co-author of Endovascular Surgery and Handbook of Endovascular Surgery. As an agreed medical evaluator, frequently when I have found patients that have had thoracic outlet syndrome, by reputation, he seems to be the man. So I asked him to appear today with his experience treating thoracic outlet syndrome. Thank you.
Good morning. It's a pleasure to be here, and hopefully I can finish on time. We'll see. That was a wonderful talk, by the way. I enjoyed that, and hopefully my talk will dovetail, but not reiterate too much, and hopefully enhance. So the definition of thoracic outlet syndrome is symptomatic compression of the neurovascular bundle at the thoracic outlet space. Symptoms, compression, neurovascular bundle, thoracic outlet space. So the criteria to diagnosing thoracic outlet is, number one, you have to have signs and symptoms. Number two, you have to have compression, and the compression has to be at the neurovascular bundle of the thoracic outlet space. And his is the difficult one. Number one and number two have to be related. And number four, there is no other compressive etiologies to explain the symptoms and signs. If you meet those 4-point criteria, then you can diagnose thoracic outlet. If you don't meet all four, it's a little difficult. Half of you in this room, if you raise your arm up, will have compression and show signs of it, but you've not had symptoms. You don't have thoracic outlet because you're not symptomatic. Okay, there are 3 types of thoracic outlet: neurogenic, venous, arterial. Now we're going to get into the rules of threes. 1, 2, 3. There are 3 areas of compression: intrascalene triangle, the costoclavicular space, and the pec minor tendon space. There are, as far as the causes, you have bony changes, you have soft tissue abnormalities, and then you have traumatic injuries such as stretch injury, and you have inflammation. Of the bony changes, it can be due to a cervical rib or a bifid clavicle or a first rib abnormalities, especially exostosis. Soft tissue anomalies can be due to congenital bands and ligaments of the surrounding area or of the scalene muscles. And there are 3 scalene muscles: anterior, medial, and the minimus, which is not described in most anatomy textbooks. The posterior scalene muscle is not part of the thoracic outlet. That goes to the second rib, not the first rib. And then you can have shoulder girdle muscular changes. So here's a diagram of it. You can see that the neurovascular bundle courses between the anterior and medial scalene muscles above the clavicle, and then it courses under the clavicle on top of the first rib, and then underneath the pec minor space. Here's a transaxillary view of the thoracic outlet space from your right to the left, anterior to posterior. You can see subclavius muscle and tendon, vein, anterior scalene muscle, artery, brachial plexus, and then either a medial scalene muscle or, in this case, a cervical rib. The cervical rib is exactly where the medial scalene muscle should be. Then you can also get congenital anomalies where the anterior scalene muscle splits into 2 and surrounds the artery and the nerve. And then you can also have a fibrous band where you have a elongated transverse cervical rib, but then it ends as a fibrous band as a functional medial scalene muscle, but now the muscle is gristle and it's a fibrous band. Now, it turns out that 80% of my patients will report some trauma ahead of time prior to their thoracic outlet onset. And the trauma is usually the neck, shoulder, girdle, upper extremities. But they can also have inflammation as well from these injuries. It's been reported that thoracic outlet occurs in about 0.3 to 2% of the population in the United States. The most common age is between the productive years of 25 to 40 years, and is mostly female, 4-to-1 ratio. Not sure why. Maybe females have smaller bony frames, have less space to work with. I'm not sure why, but that's just the facts. Now, the symptoms will depend upon whether, as you just heard, it involves a nerve, vein, or artery, or a combination thereof. And the nerves, there's two components. There's the peripheral nerves and there's the autonomic nerves, the sympathetic nervous system. So if you have neural symptoms, you can have pain, paresthesia, tingling, motor weakness, sensory deficits. If you have anatomic changes, you can have Raynaud's phenomenon, color changes, and temperature changes, the so-called RSD, or now chronic regional pain syndrome. Now look at the brachial plexus. You can see it is quite varied, and if it's compressed, you can see that it would involve a whole large area of the upper extremity. So that's why you can't pinpoint the symptoms. But one thing you can pinpoint that's very consistent is the ulnar nerve distribution, because the ulnar nerve distribution goes through the lower cord, the lower trunks, to CA-T1 nerve roots, and it sits right on top of the first rib. So that can lead to hand atrophy. You can see the hand atrophy on the patient's left hand, which is your right. Notice the absence of the interosseous muscles. You can also get RSD picture, swelling, chronic trophic changes. Now, on the venous side, you can get pain, swelling, venous distension, cyanosis, and collateral circulation across the central nerves that are compressed or occluded or thrombosed. So if you go to Venice Muscle Beach, you see all these muscular group with people, men with big bulging veins. They may have thoracic outlet. Now here's the mechanism of the thrombosis that occurs with venous thoracic outlet. Whenever you raise your arm up, you compress and stretch that vein. And if you do that repeatedly, like throw a baseball 1,000 times in a day, or spike a volleyball, or swim 10,000 strokes in a day, you can see that you can get repetitive injury to that vein. When you do that, the vein gets thrombogenic, and then it clots. And also those clots can even cause pulmonary hypertension and pulmonary embolism, and can present as chest pain. Here's a venogram showing the right brachiocephalic vein being occluded by a clot. Now, what about arterial symptoms? Well, they present with loss of pulse when you raise your arm up. They can have arm claudication. They can get thrombosis and thromboemboli, and they can present with actually finger necrosis, or a clot can go to the triceps area of a baseball pitcher and cause baseball pitcher not to be able to throw anymore. Here's an example of the stenosis of the subclavian artery right underneath the clavicle, right at the scalene triangle. Here's an angiogram showing thrombosis of the axial subclavian artery. And you can see here even the emboli down to the brachial artery from the thoracic outlet space. And that can, shows no thrombus, but now you can see vasospasm. This is RSD. Some of these patients can get post-stenotic aneurysmal degeneration of the artery because of the turbulent flow created by the stenosis. 41% of patients with neurogenic, the classic neurogenic thoracic outlet, actually present with headaches as one of the principal components. You just heard that from Dr. Braun as well. Also, note that of the few patients who present with arterial thoracic outlet, that 43% of arterial TOS patients will actually present with vertebrovascular strokes. And then 1 to 2% of patients with thoracic outlet will have underlying tumor at the thoracic outlet, such as a Pancoast tumor or metastatic breast cancer or metastatic thyroid cancer. So keep that in mind as well in the back of your mind. The diagnosis you heard all about basically is the provocative test that raises your arm, abduction, external rotation. That's the AER test, abduction, external rotation test. And that rotates the clavicle and subclavius muscle posteriorly and inferiorly and causes more compression. And this is someone doing that test. And you can do the same thing with the patient with an EMR scanner, as you heard about James Collins. And he does all these very complicated sequencing. And you can see here that the lack of signals on one side versus the other. You can see the corona view, which is showing decreased flow signals on the right side of your on the patient's right side. And here, with the arm elevated, you can see kinking and stretching of the neurovascular bundle. Dr. Collins also reported many, many years ago that you have impaired venous flow when you raise your arm up. No one paid attention to it until recently when I did. And here's an example of the venous flow void and the MRI scan. The problem with the MRI scan is that it's very nonspecific, and you can dial in and dial out anything you want. And the radiologist reading it and doing it has to be very persnickety about playing around with the software. So it's unfortunately not that precise. And then you heard about the scaling muscle block test. The problem with this test is that it's not always done well or properly. There's two sides of it, the stimulation part and the block part. And you have to make sure that the needle and the block is in the right place. If it's in the wrong place, you get a nerve block, not a scaling muscle block. And then the test is absolutely worthless. So here is Dr. Jordan does it very precisely by shooting some contrast under ultrasound guidance and under x-ray guidance and fluoroscopy guidance. That's very precise, but most people don't do it that way. So it's very operator dependent. Electrophysiologic tests, listed here. Those are to rule out other things, in my mind. Here you can see that the scaling muscle block is much more sensitive than SSCP or the EMG, nerve conduction velocity. As you might imagine, the SSCP measuring the sensory function is more sensitive than the EMG and nerve conduction, which measures the motor function. But it turns out that you can note here that the EMG is normal in majority of patients with thoracic outlet with a positive scaling block. So they're not that specific and not that reliable, and that's part of the reason it's hard to clinch the diagnosis of thoracic outlet. You have to put all these factors together and get a gestalt view of the patient, not just hang your hat on one test. The scaling muscle block, however, is also a very good predictor of who's going to do well with surgery versus not. If you have a positive block, there's a good chance you have a good outcome. If you have a negative block, well, the test is worthless. You just don't know. Here's the outcome. You can see it's a negative block, it's 50-50 chance. If you have a positive block, you have a 75% chance of having a good surgical outcome. So if you look at this 4-point criteria that I mentioned, symptoms, compression, causal relationship between the symptoms and the compression, and absence of other causes, if you just look at that, it turns out that it's very, very reliable in predicting who's going to get better and who's not. Now, what is the treatment for thoracic outlet? Conservative at first. Try everything you can. Pain medication, physical therapy, even Botox injection of the scaling muscles. If they fail, then they go to surgery. And it's traditionally first rib resection or a cervical rib resection or a scalenectomy or a pec minor tendon release, or all combination thereof. Here's a view of it. But note that you've got vein, artery, and nerve, lung underneath, phrenic nerve very close by, sitting on top of this anterior scaling muscle that you're about to cut. And you're going through this transaxillary approach through a long, narrow, dark hole. Because you got to go from here to here. So we're going through a long, narrow 6-inch tunnel. Okay? It's a very persnickety operation. You got to go in there, and sneak in long instruments and divide the scalene muscles and take out the first rib without injuring those neurovascular structures or the lung underneath. And you can also get the cervical rib out at the same time you get the first rib out. Many times the cervical rib is attached to the first rib. You take it out as one piece. So you can also at the same time, since the sympathetic nerves run right on the posterior aspect of the first rib, you can actually do a ganglionectomy through the same incision. Supraclavicular scalenectomy is not as difficult because you're not working through a long, narrow tunnel, but you are working still through a small hole, and there's a lot of important structures in the way: the phrenic nerve, the vagus nerve, the brachial plexus, subclavian artery and vein, and you got to take out the scalene muscles and the subclavius muscle and part of the medial scalene muscle, all without injuring any of those. And on the left side, you have to make sure you don't injure the thoracic duct. So this operation is not for the timid. It's a very persnickety operation, and sometimes you have to even take out a lot of scar tissue and do a little release of the fibrous bands that course literally through the brachial plexus. So in our results from UCLA, 10-year experience, I looked up all my TOS cases and see how they did. And basically, the important thing to remember is that, yes, many of them did get better, but there were complications. You can see here, the complication rate is 3%. Is that a lot or a little? I don't know. If you're the patient that got the complication, it's a lot. If you didn't get the complication, it's very little. It just depends on your perspective. But there are some major complications that are possible, not likely, but possible. Injury to the subclavian vein, long thoracic nerve, injury to the internal mammary artery requiring transfusion, pneumothorax, etc. If you use the 4-point criteria, you have a very good chance of getting better with the surgery. If you use just one of those physical exam, MRI, scalene muscle block in an isolated fashion, results are not as good. But the 4-point criteria that I showed you, it really gives you the best likelihood of proper diagnosis and doing the right operation for the right patient at the right time in the right manner. Now, how does everyone else do? They do about the same, maybe not, I mean, it's all over the map. 43% success rate all the way to 90%. Now, the problem with this, all these studies is that they're all short-term. They're all 30-day results. Now, you got to look at long-term results as well. And if you look at long-term results, then it's not so good. Or is the glass half full or half empty? At 36 months, at 3 years, half the patients now have recurrent symptoms, and they're not symptom-free after all. So surgery is not permanent. They never get 100% better, and they don't always stay better. So long-term results are very important. Now, what about axial subclavian vein thrombosis, venous thoracic outlet, which represents about 4 to 5% of thoracic outlet patients? This is a complicated, but basically the point of this is that here you see the clot right at the thoracic outlet space underneath the clavicle at the scalene triangle. Here you see it again, another thrombus with collaterals around it. And the key really is, do you thrombolyze early and do you take out the rib early? What do you do first? Most people now will do a thrombolysis, get rid of the clot, and then it gets controversial. Do you take out the rib right away or do you take out the rib later? If you take out the rib right away, okay. Okay, all right, I'll wrap things up. Okay, so anyway, you have more bleeding complications if you operate right after thrombolysis than if you wait. So I prefer to wait. And I'll skip through these slides, but there's a lot of ways of doing this. If you do it surgically, you can take out the clavicle and reconstruct the vein and all that stuff. There is a very, some people even remove the clavicle to do this operation. I prefer just to balloon angioplasty and then take out the first rib. I think it's a more humane way of doing things. Arterial TOS, anticoagulation, and then surgical decompression, and maybe if needed, sympathectomy and arterial reconstruction of the artery if there's an aneurysm. Now, the new concept I need you to talk about is jugular vein and subclavian vein stenosis. You can see here that if you do a venogram on these patients, you can identify high-grade stenosis in the jugular vein as well as the subclavian vein. People don't talk about the jugular vein, but if you think about it, if you have compression of the jugular vein and the subclavian vein, both sides, that's like having bilateral innominate vein compression. That's almost like having a subclinical SVC syndrome, and that's why a lot of these patients have headaches, engorgement, feeling lightheaded, et cetera, et cetera. And then here you see the collaterals trying to get around it. And here's before and after balloon angioplasty. And here's one way to pick it up ahead of time. Arm down, no dilated neck veins, arm up. All of a sudden, you're compressing the central vein to the external jugular vein, the collateral pops up. That's a very consistent finding. Abduct the arm, turn the head, look at the vein, and see if it's distended. And that's on the right side, this patient. Okay, now let me just go, I'm going to skip to this because this is a very important concept, and that is the patients that underwent balloon angioplasty, and it turns out a lot of these patients get better with balloon angioplasty alone, and they can avoid having surgery in many of these cases. And here, let me just show you the final results here. And with very little complications, we had a ruptured balloon in one patient and seroma from JP drain in the patient underwent operation. But here's the key. Okay, you can see that a third of the patients will get by with just balloon angioplasty alone with no need for any other surgery or any other procedure. Of the ones who had surgery, many of them can still have a supplement with balloon angioplasty. 40% of patients treated with balloon angioplasty avoided open surgery, and 50% of patients who had a venogram avoided surgery. And overall, if you count all the patients that I saw, over 500 patients in this time frame in 2000, 80% of patients can avoid open surgery with all its risk and complications. So in conclusion, most patients with classic symptoms of neurogenic TOS may have a venous component. These patients may benefit from angioplasty, and so now we need to update the classification of TOS, neurogenic, arteriovenous, and then what I call non-thrombotic venous TOS in patients with that. So here's the new treatment algorithm, which I won't bore you with, but basically you can talk to me about it later. So in summary, thoracic outlet is a complex disorder, multiple etiologies, mixed varied presentation, multiple treatment options, but you need to follow them long term, and most classic neurogenic TOS actually have a non-thrombotic venous component. Thank you very much.